so much for this invitation again. I'm sorry I was late, but I was actually thought that I should change my presentation a little bit so I could convince you a little bit more about what's on the horizon. So none of these are really relevant to this talk, so let's just go ahead. This again is the journal. I just want to encourage you all to start reading it. We're going to go to bi-monthly publications starting in 2025. We're currently every 3 months. So I'm going to talk very quickly about simulators. You know, we'll talk about postoperative detection of complications using machine learning, data acquisition using natural language processing, preoperative decision support, such as cyst surveillance using natural language processing, and computer vision. But towards the end, I'm going to focus on a new device, which I think is dramatically going to change how we do liver and probably pancreatic surgery, among other things. But just quickly, training in robotic pancreatic surgery, I think simulators are really an incredible thing. Simulators are able to be done because of artificial intelligence. Okay, so it's important to know that. You know, when I did my training, I didn't have access to decent simulators, so I think it's a really huge benefit that the young generation today can practice with simulators, something that, you know, when I was training, I could barely even see an open Whipple. And furthermore, they have simulators now that you're able to put in the CT scan findings, and you're able to simulate that surgery. So I think this is a really exciting application of artificial intelligence. So machine learning, this is a paper from Leeds. I think this is a huge game changer for us so that we can predict postoperative complications before they happen. I think this will, you know, everyone can understand how this is going to dramatically change things. You know, we can help detect things like pancreatic fistulas. Mainly, that's the main complication we would like to avoid during pancreatic surgery. So this is a paper from Daniel Hashimoto. He's one of the pioneers, young guy, but one of the pioneers in artificial intelligence surgery. He was at Harvard, I believe, when he initially did his training, but he's now at the University of Pennsylvania. He wrote a very nice review paper focusing on really the applications of AI and HPB surgery, and he focused really on machine learning, of course, for risk stratification and decision support, but also natural language processing for data generation and extraction, which is used every time you're using your iPhone. You know, that's all natural language processing. Every time you do a Google search, that's artificial intelligence. But mainly, I want to focus on computer vision. Computer vision really has dramatically changed how we do surgery and how we're going to do surgery. And you'll see why in a moment, why I'm focusing on computer vision. Okay, so these are just some other examples of artificial intelligence. Again, being able to detect people with cysts in their pancreas from radiology reports autonomously, being able to identify which of those patients should get further screening. Many times, you go back on a patient's CT scan and they had a cyst in their pancreas years ago, but nobody did anything about it because it was too small. Natural language processing can prevent things like that happening, can automatically get that patient a follow-up appointment, automatically send that patient, you know, notifications, look, you missed your appointment, come back, things like that. And then, of course, we also know, we already know a lot about the critical view of safety videos for cholecystectomy. That's being done now for sleeve gastrectomy. That's being done for pancreas resection, and it's also being done for liver resections around the world. So what is surgeomics? This is a word you're going to be hearing a lot about. You have genomics, you have radiomics, you have pathomics. What is surgeomics? Surgeomics, omics comes essentially from the Greek word that means the whole. So all of surgery. So what does that mean? Anyone who's been to tumor board knows what I'm talking about. It means what mutations does the patient have? What do the CT scan findings show? What do the pathology slides show? What does the clinical data of the patient have? You know, preoperative, postoperative, what are their comorbidities and everything? All of that is surgeomics, okay? What our goal is, as I mentioned in my previous talk, is to have video surgeomics, is to have interpretation of data during a surgery to make all of our lives easier and make surgery safer for all of our patients. An example of what we would like with video surgeomics is when to remove oligometastatic disease for a patient with pancreatic cancer. Some patients do well, most patients do poorly. An analysis of the video during surgery might be able to tell us, combined with the radiology images, with the radiomics analysis, with the analysis of the voxels of the 3D contrast, degree of contrast, or not contrast, but the degree of illumination on a single voxel, combined with all the other voxels around it, might be able to tell us those patients that are actually going to benefit from a resection of oligometastatic disease, because they'll be able to tell us the biology of the metastases. And what about how to prevent post-pancreatectomy acute pancreatitis, specifically that we see from ischemia of the pancreas, whether it's a distal pancreatectomy, a central, or a Whipple. I'll show you a slide a little bit of what that would look like. And also, when is an Appleby indicated? Appleby has a notorious high complication and mortality rate, but some people do very, very nicely from it. Wouldn't it be nice if artificial intelligence could tell us which patient would be a good candidate for that, and not just base it on our mood of the day or how we're feeling or what the rest of our OR block looks like? So this is an example of augmented reality navigation system being developed currently in China. As you can see, the Chinese have really become, in many ways, leaders in artificial intelligence. They are publishing left and right. The volumes of patients that they're able to do is really far superior to things that I'm seeing in the quote-unquote Western world. So I really encourage you to pay attention to what's going on in China. They're doing some fantastic things, and this is an example. You can see, wouldn't it be nice to have something like this during your Whipple procedure? This is something that they already have. And when they use this, they're able to, granted the OR time is 40 minutes longer, but estimated blood loss is lower when you use augmented reality in this case series. They have a decreased pancreatic fistula rate, and more importantly, their length of stay goes down from 20 days down to 11 using augmented reality. So this is a very clear example of how AI can help us all and our patients, and the bottom line for hospital systems in our C-suite. So this is an example of using ICG to detect if there's any ischemia of the transected pancreas. They're starting to combine AI with ICG analysis in real time. The idea is if you can detect ischemia, it's very hard to see if your pancreas is ischemic during surgery. I would say it's almost impossible. But with ICG and maybe even surgeomic analysis, real-time analysis, this might be a great way to tell us, you know what, you better take a little more pancreas, or you know what, maybe you need to take the whole pancreas. This patient is going to have a vicious leak. So this is another example of how AI can help us all. So if you're interested in computer vision and autonomous actions, this is 2 review papers that we wrote in Sensors. I started publishing now in computer science journals. I became so interested in the topic, I did a master's in AI, and I'm actually starting a PhD in artificial intelligence. I'm 52. That just goes to show you how important I think this topic is. So I really encourage chairmen to support young members in their department to seek additional training. Not everyone needs additional training, but I think one person at least per department needs additional training in artificial intelligence. So why am I talking about this? Histosonics. I mentioned this earlier today, and I thought, I better show you guys what's on the horizon. This is a robot. This is a robotic arm that gives targeted high amplitude therapy. It doesn't create. It's not HIFU. It's not high frequency, which creates increased temperature. It's amplitude. All it does is move the tissues around. It's currently approved in the U.S. for liver tumors. It's very interesting. I've seen it in action. It does not damage the bile ducts. It does not damage the vessels. It just kills the tumor cells. And it maintains their overall structure. So if you treat one tumor and you don't treat another tumor, you can actually see that the other tumor will shrink afterwards. There's like a tumor vaccine effect being created. So this is just what the treatment probe looks like. The robotic arm, is controlled autonomously. So this describes the mechanism of action. Too much physics for me, but essentially it's just moving the cells around until they all lyse. Okay, so the receptors and everything are left intact, but the actual cell will lyse and therefore be killed. So as you can see, 463 cases have been done at the time of this slide. You know, I talked to the rep actually, and I have no financial relationship with him, but I talked to the rep just the other day because I'm trying to get this device into my system. And I'm begging all of you liver surgeons and pancreas surgeons out there, if you hear about your interventional radiology department bringing this into your hospital, make sure you have access to it. Because if you do not have access to it, you are going to see a dramatic decrease. I'm worried you're going to see a dramatic decrease in your cases. Currently, this procedure has to be done under general anesthesia. I personally think it should be in the control of surgeons. But if we don't know about it, if we're too arrogant to think that this should be something that we do, I'm concerned that we're no longer going to have procedures, okay? So this company initially planned in 1 year to sell 30 robots. Just to give you an example, Da Vinci, when their first year of sales, they sold 1 robot, okay? So they have been on the market for less than a year. They already have 60 orders around the world. They have it at NYU. They have it at the Mayo Clinic. They have it in Dubai. They're charging, I'm not sure if I'm supposed to tell you, but I don't work for these guys, so I'm going to tell you, they're charging $50,000 a treatment, and they have a waiting list for patients to go in of already 6 months. They can't make them fast enough. If you want to buy one now, you have to wait almost a year before you can get one. So pay attention to this. Long-term data isn't out, but this is the device again. This is what the head looks like. Let me just give you an idea of, well, it's very similar to radiation oncology. It uses an ultrasound. All you need is an x-axis and a y-axis, but if you want, you can also add a z-axis. I did it myself. It's very easy to do. Once the robot knows what part that you want ablated, you hit a button and it does the rest autonomously. Okay, the patient is under general anesthesia. They wake up without any pain. They can go home the next day. It's conceivable that this could be done without general anesthesia. Okay, so this is the ultrasound on the left side. That's where you do the diagnosis, and then it creates the 3D map of the tumor. And then the device on your right actually gives the high amplitude treatment. It takes just several minutes to treat the tumor. It's not even a very long procedure. This just gives you an idea of, you know, the tumor preoperative and postoperative. It creates a nice big, this is instantaneous. It looks like this right away. It's not like when you do an ablation and you see all this scatter, you're like, I think I got the tumor, but you just see all this white, you know, fractured imagery around the tumor. You can precisely see exactly the zone of ablation. So let's keep going. So this is just what it looks like in the operating room. Again, I beg of you, if you hear this word, make sure the surgery department controls it. If you still have that kind of power in your department, use it and say, this is only for the surgeons. I'm sorry for any intervention radiologists out there. So they've already done, it's only approved for liver tumors right now. That's the Teresa trial. It's a feasibility study. The Hope for Liver is a single-arm pivotal trial for primary and secondary liver tumors. So as you can see, they also want to do it in kidney, and more importantly, they want to do it for the pancreas. So wouldn't that be interesting if you could now treat pancreatic cancer? You just ablate the tumor, you leave the pancreatic duct intact. This is a game changer potentially. Okay, so these are some papers they've done. I believe, what does that say? 230 cases. Yeah, 230 cases. Yeah, you can see from centers all around the world. The short-term results are excellent. Very few complications, if any. And the one criticism I keep hearing from stubborn liver surgeon chairmen is like, well, there are no long-term results. Okay, this is true, but if this is something that can't be ignored. That's all I'm saying, is pay attention to this. Okay, so this is just another trial, if you're interested, that's been published on this. Again, currently approved for primary and metastatic liver tumor. But I should go back because on the initial slide I showed you, you can see they're not just doing it for liver. Here, I think you can see it here. Looks like they're doing it for colorectal, neuroendocrine, pancreatic, hepatocellular, breast. Or actually, but come to think of it, these are probably all just metastases in the liver, so I digress. Okay, let me go back. So this is what I mean when I'm talking about artificial intelligence surgery. You have to change the way you think of what surgery is. You have to change the way what you think robotic surgery is. I initially wanted to show you some videos of doing a lap Whipple and all these other things, but I decided not to but I'm going to show you one thing in the beginning of this video because I think it's just interesting if I can get to it. How much time do I have left, by the way? 1 minute? Okay, so I'll stop on this one image, but maybe I won't get there. It's too slow. Oh my goodness. I just wanted to show you this narrowband imaging that we did. This was about 15 years ago. And what's interesting about this is I found that lesion without narrowband imaging. I thought I found the imaging with narrowband imaging. I removed it, did the Whipple. The frozen section was negative, but the final was positive. And wouldn't that be nice if I had artificial intelligence analyze that image and tell me that that indeed was a metastasis? Anyway, let's continue. I'm not going to go through that. We're going to skip that. We're going to skip that. We talked about the 6 levels of surgical autonomy. I just want to talk about the Geithner hype cycle. You know, we have the peak of inflated expectations around 2011. We had the trough of disillusionment around the time that we started the journal. I think we're much closer to, I think we've passed the slope of enlightenment, to be honest, and we're much closer to the plateau of productivity, which I never thought I would be saying in my lifetime. But things are moving very quickly. All of these things that you see here, virtual navigation, autonomous access, autonomous suturing, autonomous dissection, situation awareness, phase recognition, simple autonomous procedures, all of those have been accomplished. So we have complex autonomous procedures. I think this histosonics, if it's able to treat liver, pancreas, kidney tumors, what have you, I think we've obtained even that. So this is a paper if you're interested on autonomous actions. Don't have time to talk about that, but I do want to stress that we still need to understand what robotics is. And if you're interested in why I believe artificial intelligence surgery is better than current robotic-assisted surgery or is something we really have to ignore, this is a short editorial. You can read about it. And I think in the interest of time, I'm going to say thank you very much.